Today we are covering labor and delivery, specifically how the stages of labor and fetal monitoring are tested on the NCLEX. The exam will not ask you to simply define the 4 stages of labor. Instead, it will give you a scenario and expect you to identify the stage or phase and select the priority nursing action. The first stage, which is the longest, is broken down into 3 phases and is a frequent focus of exam questions. The latent phase is from 0 to 3 centimeters dilation, where contractions are mild and the mother is often sociable and excited. Your nursing role here is supportive and educational. The active phase, from 4 to 7 centimeters, is where the real work begins. Contractions become stronger and more frequent, and the mother becomes more inwardly focused. This is typically when pain medication like an epidural is requested and administered. Your key responsibility is assessing pain, monitoring maternal and fetal vitals closely, and providing comfort measures. The trickiest phase is the transition phase, from 8 to 10 centimeters. This is the most intense part of labor. The patient may feel an overwhelming urge to push, feel out of control, or experience nausea. The NCLEX loves to test this. A common question will describe a patient who is 8 centimeters dilated and feels a strong urge to bear down. The trap is to encourage pushing. The correct nursing action is to assist her with breathing techniques, like patterned panting, to prevent her from pushing against a cervix that isn't fully dilated, which can cause swelling and impede progress. The second stage of labor begins with full dilation and ends with the birth of the baby. Your focus shifts to coaching the mother through pushing efforts and monitoring the fetal response to descent. The third stage is the delivery of the placenta. Your priority here is assessing for signs of placental separation and ensuring the fundus is firm afterward to prevent hemorrhage. The fourth stage is the immediate postpartum recovery period, usually the first 1 to 4 hours after birth. The highest priority is monitoring for postpartum hemorrhage by frequently assessing the uterine fundus, lochia, and vital signs. Now let's discuss fetal heart rate monitoring, a critical and highly testable area. To master this for the exam, you must remember the mnemonic VEAL CHOP. It links the type of deceleration to its cause. V stands for variable decelerations, which are caused by C for cord compression. E is for early decelerations caused by H for head compression. A is for accelerations, which means O for OK or oxygenation is good. L is for late decelerations caused by P for placental insufficiency. The exam won't just ask you to identify a pattern, it will ask for the priority nursing intervention. Early decelerations are benign and just require monitoring as they mirror the contractions. For variable decelerations caused by cord compression, the priority is to change the mother's position to relieve pressure on the cord. However, the most critical pattern is late decelerations. These are a non-reassuring sign of fetal distress. If you see a heart rate dip that begins after the peak of the contraction, you must act immediately. The NCLEX will test your ability to prioritize these actions. Your first move is always to reposition the patient, usually to the left side, to improve placental blood flow. Then, administer oxygen via a non-rebreather mask, increase IV fluids, and importantly, discontinue oxytocin if it is infusing. These steps are all aimed at maximizing oxygen delivery to the fetus and are always the correct answer when faced with late decelerations.